Good evening, ladies and gentlemen. On behalf of my colleagues in the organizing committee of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries across the globe. This webinar is CME accredited in collaboration with NMC Specialty Hospital Dubai and sponsored by Rheumatology India, Rheumatology UAE. I would like to thank the country business manager of this company, Mr. Tawfiq Ali, for helping us and always sponsoring our program. Well, today we have eminent speakers from India and UAE. In a short while, I'll be introducing them. Today's Festival of Light, Diwali in India. I would like to wish all my Indian colleagues a happy Diwali. Well, as I said, today's topic is pediatric rheumatology, and we have eminent speakers from India, Dr. Ankur Jindal, consultant pediatric rheumatologist from PGH and Liga. From UAE, Dr. Ziad Hawabe, consultant pediatric rheumatologist from Medical Clinic Parkview Hospital, and Dr. Sadiq Sharif, consultant pediatric rheumatologist from Al Jalila Children's Hospital, Dubai. Dr. Sadiq is moderating the session today. Today we won't be having Dr. Kalpana because of Diwali. Of course, Dr. Diari Muhammad, senior consultant pediatric surgeon from Al Jalila Children's Hospital, and Dr. Muhammad Amir Tolaimat, senior pediatrician from Emirates Clinic Jumeirah, with us in the panel. Well, as usual, we have a question. I would like to request all viewers to identify these two scientists. Just mention the name and their contribution. At the end, Mr. Tawfiq will announce the name, and a token of appreciation will be given to them. Welcome to Dubai, beautiful city. Best time to come and visit. Those who have not seen, to come and see a view of Sheikh Zayed Road. Well, members of Dubai Pediatric Club then, and now on behalf of all of them and on behalf of the organizing committee, I would like once again to welcome all viewers to this webinar. In the organizing committee, myself, Dr. Rajendra Joshi, past president, Dr. Kalpana Sengupta, the secretary, Dr. Diari Muhammad, chairman of the academic affairs, Dr. Muhammad Amir Tolaimat, who is with us tonight, Dr. Ayman Jundi, Dr. Rafia Wara, Dr. Shrinavas Pandari, our honorary member, Dr. Leila Al-Bahi, and Dr. Khalid Rashid. Well, here you see Mr. Tawfiq Ali, our sponsors from the first annual conference in 2015 till today. Well, I would like to bring it to the attention of all viewers that our 8th annual Dubai Pediatric Club Conference will be held on Saturday and Sunday, 26 and 27 November 2022. It will be in two parts, physical and virtual. The physical conference will be on 26th Saturday. We will have gala program and dinner the same day. I would like to announce here that those who attend the physical conference on 26 will be given a pass to attend the gala dinner. So those who have come and attend physical conference will be our guests in the gala. On 27, we will have webinar. All can attend from all over the world. We are having eminent speakers from United States, UK, India, and UAE. Well, our 9th annual Dubai Pediatric Club Conference will be held next year on Saturday and Sunday, 29th and 30th April. Please save the dates. 9th annual Dubai Pediatric Club, Saturday and Sunday, 29th and 30th April 2023. Well, very briefly, in 5 minutes, I would like to give a brief account of pediatric history of pediatric rheumatology. And as you see here, everything starts with Hippocrates and ends with Hippocrates. There is an article in the clinical and experimental rheumatology about Hippocrates and rheumatology. You can see written by Passero and Marson, all about Hippocrates and rheumatology. Well, Al-Razi, the father of pediatrics. Well, about the father of rheumatology, Bailo, the father of rheumatology, first used the term rheumatism. to refer to joint ailments in 16th century. Well, Eric Bywaters, one of the fathers of pediatric rheumatology, commented in 1976 at the meeting of American Rheumatism Association conference on the rheumatic disease of childhood in Park City, Utah. He said, I think I saw it and it arrived, although I can't specify its birthday or place. Dr. Eric Bywaters, widely acknowledged as one of the great innovators in British rheumatology. Well, about pediatric rheumatology in the UK. Pediatric rheumatology first emerged in the UK. An establishment of Medical Research Council on Rheumatism in 1947. Based in Taplow, UK, the unit was directed by Professor Eric Bywaters. This was closely followed by centers in Europe and North America. In 1950s, under the dual leadership of Professor Bywaters and Dr. Barbara Ansell, Taplow became an international center for the treatment of children with chronic arthritis. Now about our question. Two of the pioneers in the field of pediatric rheumatology, Dr. Earl Burger and Dr. James Cassidy. About Dr. Cassidy, he was considered the father of pediatric rheumatology. Cassidy was internationally recognized for his work in pediatric rheumatology and wrote the first textbook of in this field called Textbook of Pediatric Rheumatology, you see here. Well, Dr. Boer, the internationally renowned pioneer in pediatric rheumatology, he established a rheumatology division at Texas Children's Hospital and Baylor College of Medicine. Well, here you are seeing Dr. Ansell with Dr. Boer and Dr. Cassidy, Dr. Boer. Well, this picture, this is the first meeting of pediatric rheumatologists in 1976. This was in Utah. In this conference, 59 participants pictured at the Treasure Mountain in Park City, Utah. In this conference, the formal inauguration of the specialty took place in 1976 when the American College of Rheumatology, was then known as American Rheumatism Association, sponsored the conference on pediatric rheumatic diseases in the United States. Well, about the history of the pediatric rheumatology, 13 physicians, including 2 Nobel laureates in 1932, held the first meeting of the American Committee for the Control of Rheumatism. In 5 years, it became American Rheumatic Association, and pediatric rheumatology was formally recognized as a specialty in 1991 by American Board of Pediatrics. Well, pediatric rheumatology in India. Well, it gives me a great pleasure to say that Professor Lata Kumar and Professor Surjit Singh, both my mentor and teachers, they are the pioneers in the field of pediatric rheumatology in India. Dr. Lata Kumar was the first president of Indian Rheumatology Association. Here you see Dr. Khub Chandani. He was also a speaker of the annual conference in Dubai Pediatric Club last year. He is one of the pioneers. Dr. Suchita, one of the presidents of the Indian Pediatric Rheumatology, and Dr. Surjit Singh, who first established DM Neonatology in India at PGI Chandigarh. Well, you see here, in 2001, Dr. Sujata Swani established the first department of pediatric rheumatology at Sir Gangaram Hospital, New Delhi. The rheumatology chapter of Indian Academy of Pediatrics was formed in 2001. Dr. Raju Khub Chandani was the founder sorry. Dr. Raju Kumdana was the founder convener of the Pediatric Rheumatology Society of India and is widely recognized as one of the pioneers of the pediatric rheumatology in India. Dr. Lata Kumar was the first president of the Pediatric Rheumatology Society of India 2001 to 2003. And please note here, in 2014, DM Pedia in Pediatric Rheumatology was started at PGI Chandigarh by Professor Surjit Singh. Presently, it is the only center offering DM program in pediatrics. Well, about the pediatric rheumatology in the UAE, our moderator and panelist, Dr. Sadr Sharif, a senior consultant pediatric rheumatologist at Jalila Children's Hospital, is a pioneer pediatric rheumatologist in the UAE. He was president of the Pediatric Rheumatology Arab Group. Well, I'm going to end. I will introduce our speakers. Our speaker from India, Dr. Angul Jindal, consultant pediatric rheumatologist, Department of Pediatric Clinical Immunology and Rheumatology, Advanced Pediatric Center, PGI Chandigarh, India. Dr. Ziad Ababe, consultant pediatric rheumatologist, head Pediatric Allergy, Immunology and Rheumatology Unit, Mediclinic Parkview Hospital, Dubai, UAE, and Dr. Sadr Sharif, consultant pediatric rheumatologist at Jalila Children's Hospital, Dubai, UAE. Well, once again, welcome to Dubai. Thank you very much. I'm ending here. Now I would like to request Dr. Jindal to start his talk. And after that, Dr. Ziad will present a few interesting cases, followed by panel discussion. Thank you very much. Over to Dr. Jindal.
Thank you, sir. Can you hear me, sir? Is my voice
please.
okay?
Yes, please.
And I will start sharing my screen. And please let me know if my screen is visible.
Yes, doctor. Please
okay.
go.
So, good evening, everyone, and thank you, Dr. Sora, for giving me this opportunity. So I am a consultant in the Department of Pediatrics in the unit Pediatric Allergy Immunology Unit at this premier institute in Chandigarh, India. And so Dr. Sora wanted me to talk about approach to JIA, because as I understood, this is probably the first webinar on pediatric rheumatology, and JIA is bread and butter of pediatric rheumatology. So I think if something in pediatric rheumatology has to start, this has to start with JIA. But I kept my title as a child with arthritis, because unlike adults, the practice of adult rheumatology, or you can say the practice of adult physicians, where arthritis is a very it's not a very broad group. When you see arthritis, the only thing that comes to mind is rheumatoid arthritis. Unlike children, the arthritis in children has a very broad category. It may vary from GIA to arthritis presenting with infections. It may be reactive arthritis. It may be arthritis associated with several systemic diseases. And then, because in children, there are more chances of having monogenic, genetic forms of diseases as compared to adults. So there are a lot of genetic conditions also that present in children. So rather than saying it as GIA, it may be better to discuss a child who actually presents with arthritis, and my talk would entirely be based on cases that we have encountered during our practice. So I have nothing to disclose in relation to this presentation, but I would want to ask if there is any issue with my audio or my presentation, or anything that you want, wherever you want me to stop in between, please let me know. Okay, so let's start with the definition of arthritis. So it's actually not very difficult. If you have a joint which is swollen, then you call it as arthritis, whatever be the underlying etiology. So if a joint is swollen because of bleeding in the joint, it is arthritis. If a joint is swollen because of synovial effusion, that is also arthritis. So by definition, if a joint is swollen, this is arthritis. But what if the joint is not swollen? Can this still be arthritis? Yes, because a joints like hip joint, shoulder joint, which are actually deep-seated joints, if they are inflamed, the swelling may not be very obvious. So a definition for those kind of situations has also been formulated. And if any two of the following is present, like the limitation of joint movement, pain on movement, heat or warmth overlying the joint without any visible swelling, that may also be labeled as arthritis. Now the third point, which is heat and warmth overlying the joint. Now except for a few conditions like septic arthritis and a few more, the heat or warmth overlying the joint is usually not seen in many other conditions in children. So we eventually have to finally we have to rely on limitation of the joint movement and the pain on movement as a criteria to define arthritis in children when the swelling is not very obvious. So when you approach a child with arthritis, we always ask whether a swelling is present or not. In your practice, you must have realized a lot of children present with joint pains. It's a very common presentation. That pain may be because of the growing pains. It may be of any other etiology. But if the swelling is not present in a joint, then or there are no other characteristic features of arthritis, you have to be very careful in labeling a child to have arthritis. So when the child has swelling, then you want to know whether it is painful or painless, and I'll come to that in my subsequent slides. So what is the importance of having a painful swelling or a painless swelling? So swelling can also be painless in certain conditions. And then history of trauma is also important, because although in children, if you start seeing patients with arthritis, you will realize history of trauma is usually incidental. And because children, they have very flexible joints, and the trauma usually do not lead to a joint swelling in children. So it's usually incidental. It brings a swelling into attention, but usually is not the root cause of the problem. So whenever you have a history of trauma and a child is presenting with arthritis, and everything is not fitting well, think that in mind, that the history of trauma may actually be incidental, and the cause of joint swelling may actually be something else. And I'll come to that also in my case scenarios. Now, when one very important question that one want to ask when you see a child with arthritis is whether this arthritis is acute or whether this arthritis is chronic, because the causes of acute arthritis are different while the causes of chronic arthritis are different. So I'll come to that in my case scenarios about the importance of acute and chronic history of acute and chronic arthritis. Now, another very important point that one want to ask is if the swelling is inflammatory in nature or it is non-inflammatory. So there are conditions like JIA, which is an inflammatory arthritis. There are very characteristic clinical manifestations, while there are certain conditions, like for example, a child with hemophilia bleeds into the joint. That's a non-inflammatory arthritis. So what are the characteristic features of non-inflammatory arthritis? And it is usually possible to differentiate the two conditions clinically without doing any extensive investigation. So I'll come to that also in my subsequent slides. Now, another important aspect then that one would want to ask is, if a child has come with swelling or has a feature suggestive of arthritis, you want to know the symptoms are more articular or they are more periarticular. And I'll focus on this aspect also in my subsequent slides. So articular swelling is basically, the swelling that is originating from the joints, while periarticular structures, there are a lot of structures around the joints, like the muscle, the tendons, and the swelling may or pain may arise from those structures also. And clinically, it may be possible to differentiate if the arthritis is articular in nature or periarticular in nature, and the etiology of the two is also different. So it is important to know if it is articular or periarticular. Now I have highlighted systemic features. If you have a child who has systemic features, it is usually a red flag. So if the child is having fever, is also having rash, is toxic looking, has some bleeding manifestation, lymphadenopathy or hepatosplenomegaly, that's a red flag. There are certain group of conditions that actually present with arthritis and systemic feature. So it is important to note systemic features so that one can diagnose those conditions well in time, because most of these conditions are uh, um, emergency. Some of them are life threatening. So if a child with arthritis has systemic features, that's usually a red flag. So now I'll come to the differentiation, clinical differentiation between articular and periarticular swellings. Uh, uh, so if you can see in this slide, some of the structure which are within the joints, like synovium, cartilage, the capsule of the joint. So these form the articular structure, while the periarticular structures are like tendon, bursa, ligament, muscle, and bone. Now, if you have a swelling which is articular, the swelling, the site, painful site would be diffuse. The entire joint will be painful. While if you have a periarticular swelling, for example, if you have a uh, pain at the insertion of the tendons or the bursa, usually we call it as enthesitis. You will have a focal point of pain and the tenderness. So that's a very important point by which you can actually differentiate the articular and periarticular swelling. Now, pain on movement, if you have a painful swelling in the joint, it will the movement will usually be restricted in all planes of that particular joint. While if you have a periarticular swelling, then the movement will be restricted or painful in one particular plane. So let's take an example.
Dr. Jindal,
Yes, sir.
we cannot hear you.
Okay.
Yeah, no, it's fine.
Okay. So okay. Thank you, sir. So is that clear now, sir?
Yes,
Okay. Should I repeat this slide or?
only last sentence.
Okay. So let's take an example of a hip arthritis versus a swelling or pain because of in the hip joint because of a psoas abscess. If you have a psoas abscess, it will look like that the child has hip arthritis, because the pain would be in and around the hip joint. Now, how do you differentiate? If you have a child who has hip arthritis, the movements will be restricted in all planes of the all movements at the hip joint will be restricted. While if you have a psoas abscess, the movement will only be restricted in the extension and flexion of the hip joint, while other movements like abduction, adduction, internal and external rotation will be free. So that's how you can clinically differentiate if it is articular or the periarticular nature of this pathology. Now, if you have an articular swelling, the swelling would be very commonly visible, while if you have a periarticular structure involvement, as I mentioned, like the enthesitis, the swelling will not be commonly visible around the joints. Now, another important, this is a very important slide. Now, if you have a child who has come to you with joint swelling, you want to know whether it is inflammatory in nature or non-inflammatory in nature. So as I mentioned, GIA is probably the commonest cause of inflammatory arthritis in children. Now, some of the other conditions like systemic lupus erythematosus can also present with inflammatory arthritis. While non-inflammatory arthritis like avascular necrosis, also known as Perthes disease, commonly involves the hip joint, or certain non-inflammatory arthropathy, and I'll give you one or two examples of non-inflammatory arthropathies also. So those are non-inflammatory conditions in the children. Now, the most important differentiating point between these two group of diseases is early morning stiffness. So if you have a child who has early morning stiffness lasting for 30 minutes to 1 hour, that is very characteristic clinical manifestation of inflammatory arthritis. While non-inflammatory arthritis, patients will have pain either throughout the day or more in the evening time. So that clinically, that is the most important differentiating point between the two group of disorders. Other important points are swelling. In inflammatory arthritis, the swelling would be soft tissue swelling, while in non-inflammatory arthropathies like uh, non-inflammatory conditions like non-inflammatory arthropathy, the swelling would be mostly bony swelling. And I'll show you the examples of non-inflammatory arthropathies also. Now, erythema, warmth, uh, these are important features that are present in the inflammatory arthritis, while these are absent in the non-inflammatory arthritis. Systemic features may be present in some inflammatory arthritis, but non-inflammatory group of diseases usually have do not have a systemic feature, and increased inflammatory parameters like ESR and CRP will usually be high in inflammatory inflammatory arthritis group of diseases, while non-inflammatory disorders will have normal inflammatory parameters. So it's important to differentiate between inflammatory and non-inflammatory conditions to move forward. Now, for pediatricians who want to evaluate a child who has come to them with some joint pains, or they want to rule out a joint pathology in a child, this is a very important. Can I actually remove this panel?
Your voice is not clear.
Okay, sir. I actually wanted to remove this panel, which is visible on the top of the slide. I'm not sure how to do that. But anyway, so basically this is the score, which is called as PGALS. So it's a assessment tool. So PGALS basically stands for Pediatric Gait, Arms, Leg and Spine. So it's a screening tool for musculoskeletal assessment for school age children. And this has been validated with excellent sensitivity and specificity. And the good part is that each assessment takes on an average of 2 minutes. So this assessment tool has been devised by Dr. Helen Foster from United Kingdom, and this is a very important tool for pediatricians to assess musculoskeletal complaints. So these are some of the maneuvers that you ask patients to do, and if there is any problem in any of the joints, you will be able to assess using these maneuvers. So you need not remember them, and I need not go through them in detail. But these are some of the and these are easily available, freely available on the internet. So these are various maneuvers for the arms. These are various maneuvers for the lower limbs, and these are various maneuvers for the gait and the spine. So PGALS is a very important tool to assess the musculoskeletal system in children. And if there is any pathology anywhere, one of these maneuvers would be abnormal, and so it becomes a screening tool. And then once the screening is abnormal, you can do a focused examination of the affected area. So it's a very important tool for initial assessment or screening of the musculoskeletal complaints. So I'll now come to the case scenarios. So this is a 10-year-old boy who's come with fever for 3 weeks. And now he has swelling of the multiple joints for the past 3 weeks. So it started with the right ankle for 5 days with excruciating pain. Even with the touch of the cloth, he used to have pain. This pain and swelling responded briskly to use of NSAIDs, and 2 days later he started developing swelling in the left knee, and then in a similar pattern he developed swelling of the elbows and wrist. Now, if you look at this case, this is a relatively older boy, an adolescent boy, who has symptoms going on for about 3 weeks. So this is an acute illness. This is not a chronic illness. And he has arthritis. There is no doubt about this because he has swelling of the joints. Now, the pattern of swelling is migratory. The other pattern that you commonly see in children with juvenile idiopathic arthritis is the additive pattern. When one joint is affected, the second joint is affected. So both the joints are affected together. But here the pattern is migratory. So one joint is getting improved and the other joint is getting affected. This is a very typical migratory pattern that is seen in just one disorder. And then another important point is whether this arthritis is deforming or not. So this arthritis is definitely not deforming, and there are systemic features present in this child. So whenever you have a case of arthritis, so these are some of the important points that you have to remember when you are evaluating a child. Age is very important because had this child been 2-year-old or 3-year-old, we wouldn't have thought of the condition that we are thinking in this particular child. So this child is basically having acute onset migratory polyarthritis with systemic features. So this is basically acute rheumatic fever. Now, one I want to highlight here is that the incidence of acute rheumatic fever, even in India, and I'm sure in UAE as well, has declined remarkably. Most patients nowadays do not actually present with arthritis. They usually present with indolent carditis or rheumatic heart disease, and even the incidence of rheumatic heart disease has actually declined. So one has to be very careful unless they have a very typical characteristic clinical manifestation. One has to be very careful in labeling acute rheumatic fever nowadays. So why if although the incidence of acute rheumatic fever is decreasing, but I want to bring to your attention this another entity, which is post-streptococcal reactive arthritis, and it is still common. But how do you actually distinguish between acute rheumatic fever and post-streptococcal reactive arthritis? Because these two, although the trigger is streptococcal infection, but these two are completely different entities. Now, if you see post-streptococcal reactive arthritis, there is a bimodal peak of distribution of the cases. So between 8 to 14 years and 21 to 37 years. And acute rheumatic fever, as you all know, it is almost always seen in children 5 to 15 years of age. Now, there are certain clinical manifestations by which you can differentiate the two conditions. So just like I mentioned in the previous case, acute rheumatic fever, the arthritis is migratory, it is usually transient, mainly involve the large joint. The response to NSAID is dramatic, and that it's a very debilitating condition, but it responds dramatically to the use of NSAID. And the arthritis usually do not persist for more than 6 weeks, even when either you treat or not treat, but the arthritis in acute rheumatic fever usually subsides in less than 6 weeks, and the inflammatory parameters are markedly elevated. While in post-streptococcal reactive arthritis, the arthritis may be additive, and it may involve both large and small joints, and sometimes the axial joints as well. Now, the response to NSAIDs is not as good as you see in acute rheumatic fever, and the arthritis may persist a little longer. And then there are certain other features like presence of carditis, which is seen in acute rheumatic fever. It is not seen in post-streptococcal reactive arthritis. So post-streptococcal reactive arthritis is still common, and these are the clinical manifestations by which you can actually differentiate it from acute rheumatic fever. Now let's move on to the another case. This is a very, very common case scenario, which I think all pediatricians encounter. This is a 4-year-old boy who refuses to walk for the last 2 days. Now, when he presented, he had no fever, but he had fever and upper respiratory tract infection a week ago. Now, when you examine, he has left hip pain with during movement. The hip is held in flexed and abducted position, which is the most comfortable position to accommodate more fluid in the joint. And when you did the ultrasound, it is suggestive of a left hip effusion. And on further investigation, the blood cell count and inflammatory parameters are normal. Now, this is a very common scenario. Basically, it's a transient synovitis of the hip, and usually it is seen in young toddlers, 3 to 10 years old. It's more common in boys. It's a very benign condition, but presents with sudden onset pain, limp in a unilateral hip with restriction of the range of movement. So it may be scary. It may look scary, but it's actually a very benign condition. So the clue would be that the child would be otherwise very well looking and will have a history of URI in the recent past. But if there is any doubt, if the fever is persisting, the child is sick looking, the inflammatory parameters are high, it's a good idea to rule out septic arthritis in those cases, because that's an important differential, and do a joint aspiration in those cases. But otherwise, transient synovitis of hip usually responds to simple analgesia and rest within 24 to 48 hours. So it's a very, very common condition seen in pediatric practice. Now let's move on to the another case. Now this is a 3-year-old boy who refuses to walk for the last 1 week. Now he has high-grade fever, and when you examine, he has significant pain in all movements at right hip. So no doubt that he has right hip arthritis, but he also has systemic features in the form of fever. Now, when you examine, he also is looking sick, and when you evaluate this child, he also has elevated WBC count. Now, this child has acute onset arthritis of the hip joint, single joint, and is toxic looking. Now, that is the typical case scenario for septic arthritis. A few words about this condition. It's a clinical emergency. The most common infective organism is Staphylococcus aureus, and Mostly it is seen in younger children, less than 2, but may also be seen in children less than 5. And as the age advances, the frequency of septic arthritis decreases. Fever, malaise, and prominent localizing signs such as erythema, local heat, and significant pain at the affected joint. These are some of the important clinical features. And as I mentioned, in any joint pathology, the joint is kept in a position that maximizes the intracapsular volume. So if you suspect septic arthritis, it's important to do the joint aspiration and culture as soon as possible. Initial broad spectrum antimicrobials following joint aspiration and blood culture, and then it can be modified as per the sensitivity report. And the total recommended antibiotic course is for at least 6 weeks. Now there are certain caution that I want you to remember. If you have a child who has presented with features that look like septic arthritis, but he's a relatively older child, you have to be cautious, because as I mentioned, in children more than 5 years, the frequency of septic arthritis reduces dramatically. Now, children who have more than one joint involvement, so that is another case where you should not upfront think of septic arthritis. Now, children with chronic history going on for 6 to 8 weeks or even longer, you have to be careful in labeling that child to have septic arthritis, even if the fever is persisting. And in these situations, refrain yourself from referring to an orthopedician for arthrotomy, because we've seen several cases of inflammatory arthritis wherein it was labeled as septic arthritis, the joint arthrotomy was done, and a joint which could have otherwise become normal just with medical management is left with permanent deformity. So be careful when you label a child to have septic arthritis, in these situations. Let's move to another case. So this is a 6-year-old girl. Now we actually go to the JIA group of diseases. This is a 6-year-old girl, walks into OPD with a limp. Now she doesn't bear weight on the left lower limb. And when you examine, as you see in this photograph, she has swelling of left knee with pain for the past 2 months. No fever, she's active, non-sick, she's walking, but although walking with difficulty, but she's able to walk. And on examination, she has left knee joint, which is swollen and tender. The other joints are normal. Now her inflammatory parameters appear to be normal, and a tuberculin skin test to rule out tuberculosis is also negative, and the chest X-ray is also normal. Now this is a typical case scenario for juvenile idiopathic arthritis, because here the history is more prolonged. The history is for 2 months. This is not an acute arthritis, this is chronic arthritis. So this is a typical clinical manifestation of oligoarthritis or oligoarticular GIA. So both these terms are used interchangeably depending on the classification criteria that you use. So if you have less than 4 joint involvement, commonly affecting the knee joint, it is more common in girls as compared to boys. And the child is otherwise would be very well looking, will present just with the limp. And one investigation that must always be carried out in these patients is anti-nuclear antibody. And when anti-nuclear antibody is positive, along with arthritis, oligoarthritis, especially in a girl child, these patients are at very high risk of uveitis. And this uveitis would be asymptomatic, and you have to actually screen these patients using slit lamp to identify uveitis. Otherwise, it will be missed, and these patients need regular screening. So this is a typical case scenario of oligoarthritis or oligoarticular GIA. And although I'm not focusing much on the treatment, but these patients usually may respond to NSAIDs. If not, then we give them intraarticular corticosteroids. And even if they're not responding to even that treatment, then we start them on disease-modifying anti-rheumatic drugs. And methotrexate is the choice of anti-rheumatic drugs in most of these patients. So another group of GIA is polyarthritis or polyarticular GIA, wherein based on the number of joints, so if the joints are affected, number of joints which are affected are more than equal to 5, then we call it as polyarthritis. Now, polyarthritis or polyarticular GIA could be rheumatoid factor negative or rheumatoid factor positive. Now, the rheumatoid factor positive group of polyarticular GIA, it actually resembles the adult rheumatoid arthritis, while the rheumatoid factor negative GIA is actually a different entity. So, RF negative polyarticular GIA usually presents in younger children, 2 to 4 years of age, or sometime in 6 to 12 years of age as well. Here the females are more commonly affected than the males. So if you have a male presenting with the polyarticular GIA rheumatoid factor negative, be cautious because it's much more common in females. The number of affected joints as compared to the rheumatoid factor positive GIA tends to be less, and the pattern of involvement is more asymmetric. While rheumatoid factor positive GIA tends to have more number of joint involvement, and the pattern is more symmetric. Now, the knee, wrist, and ankle are the most commonly affected joint, and TMJ and cervical spine may also be involved. The rheumatoid factor positive polyarticular GIA or polyarthritis, it closely resembles the adult rheumatoid arthritis, and again the females are much more commonly affected, and usually it starts in the adolescent age group. And when it presents in the children or adolescent age group, it tends to persist in the adulthood, and it's a very severely deforming kind of arthritis, and it may affect both large and small joints. It usually has a very symmetrical pattern of arthritis affecting symmetrically both the sides of the upper and lower limbs, and it may affect the metacarpophalangeal and proximal interphalangeal joints. Typically, the distal interphalangeal joint is not affected in this condition, and if left untreated, these patients present with deformities. So now let's move on to the another case. So this is a 5-year-old boy who presents with the high spiking fever for past 15 days. And as I said, when a child with arthritis has fever, it's a red flag. So on examination, this patient has pain and swelling in the left knee joint. So single joint involvement, history for 15 days, and this patient is febrile. He's otherwise not sick looking, but on examination, he has pallor, he also has lymphadenopathy, and he also has hepatosplenomegaly. And when we did the chest X-ray, he also had cardiomegaly with a CT ratio of 55%. Echocardiography showed pericardial effusion. So the cardiomegaly was actually because of the pericardial effusion. And he also has neutrophilic leukocytosis, and the platelets are increased. So he has thrombocytosis and high inflammatory parameters. Now, when this child was admitted with us during hospitalization, you can see he started developing this rash, and this was evanescent rash present mostly during the fever spike. And when this fever subsided, the rash also subsided. So when the next spike of fever comes, he starts developing this rash again. So this is a typical evanescent kind of rash seen in this child. Now, this entity is systemic juvenile idiopathic arthritis, which is basically characterized by arthritis in one or more joints and fever of at least 2 weeks duration, that is quotidian for at least 3 days. So in addition, children must have one or more of the following findings: evanescent erythematous rash, hepatomegaly or splenomegaly, lymph node enlargement, and serositis. So the index patient that I just described had rash, he had hepatomegaly, he had lymph node enlargement, he had serositis, so he had arthritis, and the fever was persisting. So this is a typical clinical manifestation of systemic juvenile idiopathic arthritis. Now, as I described this case, this patient had typical clinical manifestations of systemic GIA, but that may not be the case in every time you see a child with systemic GIA. So most of these patients actually present with just fever, and sometimes they also have arthritis. When you have arthritis, it's easy to make out the diagnosis of systemic GIA, but sometimes these patients just present with fever, high inflammatory parameters, and thrombocytosis, and then you need an experienced hand to diagnose these group of diseases. Now, the classification of systemic GIA is actually a little bit different from the overall classification of juvenile rheumatoid or juvenile idiopathic arthritis. So herein, the duration of disease, as you see, to classify a child to have GIA, the duration of disease is mentioned to have 6 weeks or longer. Now, but in systemic GIA, it is said that the duration should not be. I mean, the 2 weeks of duration is also acceptable, because if you miss this condition, and if you keep waiting for 6 weeks, you end up creating difficulty for these patients, because these patients may develop sometimes then develop some life-threatening complication, which I'll show in the subsequent slides. So systemic GIA is a diagnosis of exclusion. So whenever you make a diagnosis of systemic GIA, it's important to rule out some of the infections. So for example, in our country, we always rule out tuberculosis, because that can mimic any of these diseases. And occasionally, or almost always, I would say, we rule out malignancy in these patients. So whenever we initiate steroids to a patient with systemic GIA, almost always we do a bone marrow to rule out malignancy. One should keep a very high index of suspicion in children for systemic GIA who have unexplained fever. They also have rash or arthritis, but as I mentioned, many of these patients just present with fever and no other clinical manifestations. And if they have no other explanation for the fever, with some experience, you can diagnose these children to have systemic GIA just with fever and no other clinical manifestations. Now, macrophage activation syndrome is a potentially life-threatening manifestation wherein these patients start developing. So this condition actually present like HLH. So it's a very fulminant condition, and if you leave untreated, these patients may die. Now let's move on to the another case. So this is an 11-year-old boy who presented with swelling of right ankle for the past 3 months, and also had difficulty in walking. Now again, so what is different in this case as compared to many other cases that we discussed? So this is an adolescent boy. It's not a girl, it's a boy, and he's having swelling of the ankle joint, which is going on for past 3 months. So it's a chronic arthritis, but it's a boy. So on examination also, this child, as you can see in this figure, has right ankle swelling, and he has no other systemic feature. But in addition, he also had point tenderness over insertion of the tendo achilles in the right foot. So this is basically enthesitis. So if you have a adolescent boy who is presenting with lower limb asymmetric arthritis, which is going on for few weeks, so this is a typical clinical manifestation of enthesitis related arthritis. And this is one arthritis which is much more common in boys as compared to girls. So if you have a adolescent boy who is presenting with lower limb arthritis, do think of this entity. So most of these patients are HLA-B27 positive, and you may also get a family history. Now, unlike the kind of uveitis that I described in patients with the oligoarticular or polyarticular group of GIA, the uveitis in enthesitis related arthritis is symptomatic. So they will present with redness of the eyes. And this may develop in as many as 7 to 10% of all cases with enthesitis related arthritis. So it's a common entity, but the good part is that it presents with symptoms. So it will be, you need not actually screen them frequently. It will present with redness of the eyes, and it can then be diagnosed. Now, these are some of the common sites of enthesitis that you have to look for. So you can see around the knee joint. So we typically call it as 2 o'clock position, 6 o'clock position, and the 10 o'clock position. And then the insertion of the tendo achilles joint are around the ankle, and the insertion of the plantar fascia on the sole of the foot. So these are some of the common sites for examination for enthesitis. Now let's move to another case. So this is an 11-year-old boy, again an adolescent boy who has limped for the past 2 months.
Jindal, we have few minutes.
Okay, sorry sir, I'll finish it. Right, sir. So this boy has left knee arthritis for past 2 months, and the parents reported that he has history of trauma while playing, and this was prior to the onset of swelling, and they came with the MRI report, which was suggestive of effusion and synovial thickening. And he was actually being treated as traumatic knee injury with NSAIDs, but had no response. So as I mentioned in the beginning of my presentation, the history of trauma may actually be incidental. And when we evaluated this child, this patient had nail pitting, and one of the his father actually had was being treated with the topical steroids for psoriasis, and this patient also had these psoriatic lesions over the legs. So this was a typical clinical presentation of psoriatic arthritis, and as I mentioned, trauma in many of these cases may just be incidental. So psoriatic arthritis, I'll not go, let's not go into details of these, but psoriatic arthritis can present in the younger age group as well as in the relatively older boys. When it presents in the younger age group, it behaves like the polyarthritis that I just described, while if it is presenting in the older age group, it presents like enthesitis related arthritis with increased risk of spondyloarthropathy. Now, dactylitis and involvement of the distal interphalangeal joint. Whenever you see in a child with arthritis to have dactylitis, which is basically the uniform swelling of the fingers, and there is involvement of the distal interphalangeal joint, that is a very characteristic clinical manifestation of psoriatic arthritis. Now, some of the GIA mimics. So this is a 4-year-old boy who was symptomatic for the past 6 days. And he had history of the left knee swelling and difficulty walking. And he also had fever for 2 days at the onset of illness. While he came to us, he had no fever. And he had pain abdomen, neutrophilic leukocytosis, thrombocytosis, high ESR and high CRP. Now at the face of it, it looks like a septic arthritis. But when we evaluated, he had these kind of rashes on the forearm. And so this is the typical clinical manifestation of Inox Conlan-Purpura. Now, it's a very common childhood vasculitis. And some of these patients, in fact, 2/3 of these cases may present with arthritis or arthralgia, and it's usually a large joint involvement and usually responds to analgesics. Now, a few more case scenarios. I'll quickly wind it up.
Dr.
So
Jindal, we will discuss rest in the panel discussion.
Okay, sir. Sure,
If
sir.
you
So
allow.
maybe, yeah, sure, sir. So maybe, should I move on to the concluding slide, sir?
Yes, please.
Okay, right. So I'll go to the concluding slide. Right. So, as I mentioned at the beginning of my presentation, in adults, diagnosis of arthritis is not very difficult. But in children, as I mentioned through my cases, the differentials are very wide. And this is the famous saying from Sir William Osler that when a patient with arthritis walks in the front door, I feel like leaving out the back door. So the diagnosis of arthritis in children can sometimes be incredibly difficult. But these are some of the tips. So if you have a young girl, lower limb, in few joints involvement, this is oligoarticular GIA, and then you have to do ANA and screen for uveitis. Old boy, lower limb, few joints, this is usually HLA-B27 related arthritis. They present with acute symptomatic uveitis. Adolescent girl, multiple small and large joints, deforming arthritis, typically rheumatoid factor positive, and it has a poor prognosis. Now, if you have a presence of systemic feature like high-grade fever, evanescent rash, think of systemic GIA. It's a diagnosis of exclusion, so you have to rule out infections and malignancy. Now, it's important to study the pattern of joint involvement associated systemic features that often guide the diagnosis. I think maybe I can skip this slide, but these are some of the investigations that must be done in all patients with, in whom you are suspecting GIA. And these are some of the investigations on the right that I mentioned can be done in selected cases, just like the cases that I presented. So need not do X-ray in all patients. You should do X-ray in some selected group of patients. But what I wanted to highlight is that these investigations like anti-CCP, ANCA, an arthritis panel or rheumatology panel, uric acid, and most importantly, arthrotomy should never be done in patient with GIA. These sometimes can be dangerous and must not be done in any patient with GIA. This is my concluding slide, and I think I can leave here.
Thank you very much, Dr. Jindal, for excellent presentation. In the panel discussion, we'll discuss about all this. Now, I would like to request Dr. Ziad Hababek, Senior Consultant Pediatric Rheumatologist at Mediclinic Parkview Hospital, to start his talk. After that, we will start our panel discussion. Over to you, Dr. Ziad, please. You are mute, Dr. Ziad, you are mute.
Okay, I'm sharing my screen now. Can you see my screen?
Yes.
Yeah, thank you for this opportunity to talk to this to the colleagues and panel and to discuss various aspects of arthritis. I'll try to be quick and stick to my time of 20 minutes. I just go over a few cases with some messages. Thanks for Dr. Jindal for highlighting a thorough lecture, highlighting the important aspects and the basic concepts in juvenile, acute and chronic arthritis. So I will start straight away. My topic will be inflammatory arthritis, juvenile idiopathic arthritis, and beyond. So the 4 case presentation, actually there are 4, not 3, with the overview and take-home messages. So case number 1 was referred by one of the colleagues. He's 33 months old boy, referred at end of September with difficulty walking and with knee and hands arthritis and muscle weakness as well. Mom reported a viral rash 2 weeks or 3 weeks before observing this joint swelling and muscle weakness. He was diagnosed as viral hand, foot, mouth disease. The fever stopped and the rash stopped, but there was some hyperpigmentation of the cheeks and palms. His family history is unremarkable. Is remarkable for a brother died with neuroblastoma, but no autoimmune conditions. So examination revealed multiple arthritis with significant effusion, limitation of movement was remarkable in both knees and wrist, as well as hips, with the flexion deformity involving the right middle and ring proximal interphalangeal joints. His cervical spine mobility was also painful and slightly limited. He showed waddling gait, myopathic gait with the proximal weakness. Picture will follow on the coming slide. The weakness was not that bad. It's not getting him to bed. He can rise from the bed and he can walk with difficulty. The power was almost 2 to 3/5 in the proximal muscles. His laboratory data was done in the referring hospital. CRB, ESR were normal, blood counts were normal, and so were ANA and rheumatoid factors and anti-CCP. Ferritin was high at 500, LDH was 618, raised creatinine kinase, aldolase was normal, and AST was 369, ALT 162. These investigations were repeated when he presented to my clinic and almost showed the same raised muscle enzymes and ferritin. D-dimer was high at 5.7. Triglycerides were also high at 519. Lipid profile not yet. Result is not available yet. We did myocytes antibodies and they came to be positive for anti-MDA5 antibodies, anti-melanoma differentiating 5 antibodies. His X-ray, chest, ultrasound, abdomen, and cardiac evaluation were normal. And the eye examination was not showing any uveitis. So these pictures were taken with consent of the parents and showing disfiguring arthritis in the left. This is the left knee. Both knees also, the right knee was also involved, but less than the left knee, both showing swelling and flexion contracture and limited mobility. And this is his gait. You can notice the waddling, myopathic gait of this unfortunate child and tendency even to fall. And 2 weeks later, 1 to 2 weeks later after presentation and after starting treatment with the steroids, hyperpigmented plaques with ulcerations on both axillae were evident. So you can notice the skin ulceration in both pictures. So the working diagnosis was autoimmune myositis, dermatomyositis, when the skin involvement was evident, anti-MDA5 related with inflammatory polyarthritis. And after consultation with colleagues from international group of pediatric rheumatology lists here, this is an email group, I posted the case, and we came to conclusion that heavy immune suppression must be started, monthly IVIG 2 gram per kilogram for 6 cycles over 6 months with pulse steroids, and preferably rituximab to be started to prevent disabling and grave skin involvement and lung involvement. In this type of myositis, interstitial lung disease is a problem. Skin involvement is a problem. While joints, it's reported that it is not erosive, it's not damaging or destructive joint involvement. With other DMARD like cyclosporine or mycophenolate and daily steroids for up to 3 months. We need, of course, to protect him against infection, and PCB prophylaxis with Septrin must be done. Comprehensive care and pulmonary consultation, chest CT, muscle MRI, and EMG must be also done with a close monitoring of his biochemical data, and blood counts should be commenced. But unfortunately, the insurance, because of insurance issue, child interrupted the care, and he did not come since 2 weeks to the hospital. I don't know where did they go. They went initially to their home country in UK in a planned visit before. I don't know if they came back to UAE or yet to settle the insurance and start the treatment. Otherwise, things will be delayed. So the important lessons from this case is that not all arthritis mean juvenile idiopathic arthritis. We have to consider other types of connective tissue or autoimmune conditions that can be presented or involve the joint. Careful attention to the skin and muscle examination and other organs must be considered at diagnosis and during follow-up. Evident synovitis must be looked for by imaging. Ultrasound now is a very non-invasive objective tool, especially in the small joints. MRI with showing enhanced uptake and proving that this is true synovitis, or if there is no uptake, then there is no synovial involvement in cases in which arthritis is not synovitis of GIA. In particular, imaging or evident synovitis must be documented in small joints, young ages, to look for signs of erosions or enhanced uptake. So these are some of the autoimmune conditions that can be presented or associated with arthritis. SLE arthritis is reported in 50% of cases. It might be potentially destructive, and many more of lupus patients, maybe it is transient. Dermatomyositis up to 1/3, maybe 25 to 50%, and scleroderma and other forms of autoimmune or connective tissue disease like connection line pair or Kawasaki disease. Then I move to case number 2, which are family of 3 brothers actually. First, 2 brothers presented to the clinic in 2020. The older son was 12 years old. His younger brother was 7 years old. Both presented with history of recurrent knee arthritis. They descended from Jordanian Palestinian family. The first one, Omar, he had a history of right knee swelling associated with fever at the age of 6 years. So 6 years before his presentation to my clinic. At that time, he was admitted for 2 weeks and had intermittent episodes of joint swelling with fever. He was managed as septic arthritis by arthrotomy and IV antibiotics, but the episodes were recurring since then with a brief fever and joint pain. Knee swelling recurred 3 months prior to this admission or presentation, and was also managed by joint aspiration. So look to his knee after repeated arthrotomy and aspiration of the joints, which could be avoided if the diagnosis was correct from the start. And the imaging done was before the surgery last 3 months, was showing minimal joint effusion with no synovial hypertrophy and no joint line destruction and no erosions. Now, his younger brother also presented at the same time with arthritis. The first episode was at 4 years old, and he had a history of knee swelling twice, once in the right knee, another in the left knee, and managed both times by the orthopedic surgeon. Septic arthritis with surgical drainage. History of fever was evident, and there was history of abdominal pain as well during these attacks. So these are some of the lab data for the second case. Leukocytosis, mild anemia, ESR was high, and the LDH was little elevated, and the septic workup or the infectious secrete was negative, no growth in the synovial culture. White BCs in the synovial fluid was raised at 32,000 and showing neutrophil predominant. So we thought of periodic fever, namely FMF, based on the family history, on periodic symptoms and signs involving the serosal membrane, including the joints, and the genetic analysis came back to show heterozygous mutation at M694V. And both were started on colchicine and followed up 2 months later. During this period, a third child, their younger brother, who is 2 years old, was presented with limping at the end of the day without joint swelling and was complaining of fever. And we ordered the genetic test. Unfortunately, the insurance did not cover for this child, and so we left with the clinical diagnosis of possible or probable familial Mediterranean fever, like his brothers. Both the brothers, during follow-up, Omar and Ryan, were showing remarkable improvement in colchicine with no recurring episodes of joint or fever. Their third brother was also started on colchicine. So 6 months after treatment, all 3 of them were doing remarkably well with no recurrence of fever or synovitis episodes. So case 3, she was 2.5 years, presented in 2020 in August, after 4 months history of left knee arthritis. In May, she was seen by a pediatrician, referred to orthopedic surgery, MRI done and showed left knee synovitis, and lab were normal, eyes were not checked, and unfortunately, unneeded and damaging arthrotomy was performed on her left knee. as shown in this picture. And despite this clinical presentation and MRI proof of synovitis, they went and did the surgery and took biopsy, which proved, of course, chronic synovitis. MTX was commenced after that in a dose of 5 milligram orally. When presented in August, her right knee, her left knee was left with significant flexion contracture, and the right knee and right ankle start to show swelling and limitation. Steroid injection was given in both right knee and right ankle, and biologic DMARD was added after 3 months of incomplete response to MTX. And despite optimum treatment and response of other joints, the child was left with fixed flexion deformity of the left knee. MRI repeated for the left knee was not showing any active synovitis, but this is the probably the damage of the unneeded arthrotomy that was carried out at the start of her disease. You can notice how the flexion is limited in her left knee. The lessons from case 2 and 3, intermittent nature of arthritis with fever makes it unlikely to be juvenile idiopathic arthritis. Remember that GIA has constant findings all through with persistent arthritis more than 6 weeks. Periodicity of symptoms and signs with return to baseline in between in children from Middle Eastern ancestries should alert us to possibility of autoinflammatory disease and FMF in particular. Unjustified arthrotomy is damaging and can leave the child with long-lasting deformity and functional limitation. Late diagnosis of GIA can lead to functional joint damage, leg length discrepancy, and uveitis, which is potentially blinding disease. So case 4, which is the last in my series, is 14 years. She presented to me with right knee pain for 4 weeks, mild swelling and limitation of movement, routine investigations, inflammatory markers were normal, all workup was negative, eyes were normal, and she was found to have right knee arthritis, monoarthritis. And after 6 weeks of persistence of this synovitis and MRI showing enhanced uptake of synovial membrane, we injected the joint, and you can see the impressive response in these 2 MRI. To the right of the screen is the MRI before treatment, before steroid injection with the triamcinolone, and to the left, MRI was repeated 4 weeks later and showing that the synovium is almost free of active inflammation. And we can see this is a transverse view. We can see this in the sagittal view of her right knee. The right is the diseased one before the treatment, the left is the after injection. So just reminder, this is from textbook of Pediatric Rheumatology. Arthritis definition is well known, that's swelling or effusion and or presence of 2 of the following signs: limitation, tenderness, or pain on motion, hotness in 1 or more joints. This is just a nice illustration of scheme of the picture of the target organ, target tissue in the process of synovitis, which is the synovium. To the left of the screen is the normal synovium, which is healthy and not inflamed. You can see here, and look how disturbed is the picture on the right, showing active synovitis, hyperplasia of the synovium, and you can see here the site of bony erosion, which might happen if the arthritis is left without treatment. And look how actively other cells are interplaying in this inflammation. So this is just to remind you the treatment algorithm of oligoarthritis by American College of Rheumatology latest guidance. Intra-articular steroids come first, and the preferred agent is triamcinolone, hexacetonide or acetonide if it's not available, but should be triamcinolone for better outcome. This is the well-studied steroids. Or a trial of non-steroidals that you should not extend more than 4 weeks. If there is incomplete response, then you start non-biologic DMARD. If there is complete response, we can continue non-steroidal and observe. If there is no response to non-biological DMARD, then we have to add biologic DMARD, TNF preferred maybe. Remember these risk factors. Joints like ankle, wrist, hip, and TMG are high-risk joints. Erosive disease at the presentation means late diagnosis. Delay in diagnosis is a risk. Elevated inflammatory markers in oligoarthritis is a bad prognostic factors or a high risk, put the patient at high risk of joint damage, and symmetrical disease also put the patient at high risk of joint damage. I want just to remind you with some of the mimics of arthritis, which may be serious enough that we should bear in mind when we are approaching a child with arthritis. Malignancy, in particular, ALL, neuroblastoma, and bone tumor should be borne in mind. I have seen cases falsely diagnosed with Guillain-Barré syndrome and falsely diagnosed with arthritis and who have hypotonia and Guillain-Barré syndromes. I have seen case of missed brain tumors who was referred as joint issue or joint problem. Genetic arthropathy and pseudoarthropathies in which synovitis is not there, and there is no proof of synovitis, but still the joints showing limitation contractures due to inherited factors causing some periarticular damage. And I want you also to remember that a persistent limb in a child, even with history of trauma, which can be evident in up to 50% of GIA or malignancy even patients, it should alert us to the probable diagnosis of GIA and sinister causes like ALL neuroblastoma. Of note, GIA is not so painful conditions. Extreme joint pain should make you think of other conditions other than GIA, like acute cases or malignancy, FMF, rheumatic fever. But GIA pain is not so intense. The worst arthritis pain I have seen is in FMF and rheumatic fever. It's even not to the degree of the findings on the clinical exam. And thank you for listening to me and giving me this opportunity.
Thank you very much, Dr. Zia, for the excellent presentation of these interesting cases. Now, I would like to request all panelists to join Dr. Jindal, Dr. Ziad, Dr. Sader, Dr. Amir, Dr. Diari. I would like to request our moderator, Dr. Sader, Senior Consultant Pediatric Rheumatologist at Al Jalila Children's Hospital and one of the pioneer rheumatologists in UAE, to start the panel. Dr. Amir and Dr. Diari, they will help. Please, Dr. Sader, please start the panel.
Okay, assalamu alaikum. Hi, everybody. Thank you, Dr. Ziad and Dr. Jindal, for the talks. I think the message was very clear. It's about when the arthritis is not GIA. I think you took us through what is joint pain, how we differentiate between traumatic and inflammatory joint pain, and if it is inflammatory, how we differentiate between acute and chronic, and when we should think about GIA and when we shouldn't think about GIA, because I think it's a very important message. And I think it's all in the definition of the GIA, where you should diagnose arthritis, and not only that, but that arthritis should be there for more than 6 weeks before you even put GIA in your differential diagnosis. So if we look at the cases that Dr. Ziad presented, I think those arthritis were actually not chronic. They're either intermittent or acute. So when you are in doubt, don't jump and make a diagnosis and just keep investigating. And usually the case will declare itself with time. So thank you very much. And I think we need to look if there are questions. I think there are 3 or 4 questions actually in the Q&A. So I will try to read the questions and direct them to the speakers. So the first question from Ram, how to differentiate early onset monoarticular systemic GIA from septic arthritis? Maybe we can ask Dr. Jindal to answer that question since he brought up this. I think what the doctor who was asking this question means is how you differentiate if your patient has systemic onset and one joint affected. How can you say that this is not septic arthritis because the patient will have fever, I assume. So how would you differentiate between the two? Dr. Jindal?
Okay, thank you, sir. It's a very important question. As I mentioned, systemic GIA is a diagnosis of exclusion. You have to exclude several causes, including, septic arthritis. The septic arthritis, the child would be sick looking. Unlike, as I mentioned, the case of systemic GIA, the child will not be very sick looking. In systemic GIA, there can be more than one joint involvement. In septic arthritis, it is usually a single joint involvement. In septic arthritis, usually the joints that are involved are the hip joint, knee joint, while in systemic GIA, other joints may also be involved. Otherwise, and if you look at the age of the children, the children with septic arthritis are usually very young, usually less than 2 and sometimes less than 5, while children with systemic GIA are usually more than 2 years of age. And but otherwise, based on laboratory investigations, both these conditions will have high ESR CRP. Thrombocytosis is a very typical lab feature of systemic GIA, but in patients with septic arthritis, usually they don't have thrombocytosis. But again, if in doubt, it is always better to aspirate the joint and send it for culture.
Yeah, I'll just add something which I think you mentioned in the definition. Usually, children with systemic onset, they usually present with pyrexia of unknown origin. They usually have 2-3 weeks history of fever, and then they might have the rash and then they develop arthritis. Very unlikely that they develop the arthritis during the acute phase. And obviously, we all know that you cannot have septic arthritis for 2 weeks. That would have been too late to diagnose. The history is very important. It does give you a clue, but I agree with you that if you are in doubt, you have got to rule infections out because that's what can kill the patient or can actually cause damage to the joint. So yes, if you are in doubt, maybe you need to aspirate the joint, but usually the clue is in the history and in the other clinical features. The neutrophilia can happen in both cases. Actually, neutrophilia is a common feature in systemic, but the ferritin is usually helpful. Yeah, thank you very much, Dr. Jindal. The next question is from Rafia, Dr. Rafia. Please tell us about reactive arthritis for throat infection due to streptococcal or bronchitis due to mycoplasma infection. Should we use steroid, oral, or ibuprofen? So basically, it's a question about how you treat reactive arthritis and if there is any special treatment if the cause is mycoplasma. Maybe again, Dr. Jindal, because you talked about reactive arthritis, if you can answer the question, and then maybe we can hear from Dr. Ziad if he has a different opinion.
Yeah, so if it's about mycoplasma-induced reactive arthritis, so mycoplasma-induced reactive arthritis we see in conditions in primary immune deficiency diseases, such as X-linked agammaglobulinemia and common variable immunodeficiency. So those are the group of diseases where we see mycoplasma-induced arthritis. But otherwise, also mycoplasma can cause arthritis. But if you have mycoplasma-induced arthritis, I mean, that is a group of diseases that you also have to think of. These patients do respond only to analgesics. But if you have a mycoplasma as a trigger, we also have to give azithromycin So now if you have an antibody deficiency state, we give it for approximately 4 weeks. But if there is no obvious immune deficiency, 10 to 14 days should also be enough.
I think Dr. Rafia means that if you had a patient with a previous infection of mycoplasma, then came with a picture of reactive arthritis, would you treat that different from any other post-infectious reactive arthritis?
Okay, I got it, sir. Now, okay,
Not
so
a mycoplasma
no,
infecting the joint. Yeah.
no, the line of treatment will not be different. It will be treated as any other reactive arthritis. So start with NSAIDs, and if sometimes reactive arthritis can be very debilitating, and maybe a short course of steroids may be helpful in those cases.
Yeah. Dr. Ziad, do you want to add anything?
In context of post-strep arthritis, as Dr. Jindal mentioned in his lecture, penicillin should be given in addition to anti-inflammatory treatment, whether non-steroidal, and it's known that they are poorly responsive to non-steroidal. If the arthritis is problematic, we can add short course of steroids.
Yeah.
And the course of penicillin should be for 1 year.
Usually, yeah, we treat with for post-strep reactive arthritis. We treat for I usually treat for 1 year of monthly intramuscular penicillin. Usually, I give it 12 months. I think this is what most of the evidence are saying. Usually, that should be good enough. I usually worry about using steroid. I try not to use steroids unless I really have to, because I've always worry about other possible diagnoses, especially malignancy. So I always try to, get it resolved with non-steroidal. Most patients actually will get better, but I agree some cases actually might be proven difficult and not responding well to reactive. The other thing I would like to add is we should think about doing stool calprotectin in these cases. I had cases actually were diagnosed as reactive arthritis, but they kept relapsing. And with the stool calprotectin was very high, and the child diagnosed with inflammatory bowel disease. So if they come, if they have recurrent episodes, I would always think about doing stool calprotectin to rule out the possibility of reactive, of IBD. Then we have another question from Dr. I think Ashraf. Is there a rule for hydroxychloroquine and FMF, Dr. Ziad?
Hydroxychloroquine is anti-inflammatory medicine, but there is no rule in FMF. The first line of treatment is colchicine, yes. And there is no description in the literature of use of hydroxychloroquine. I don't know if anyone is aware of any study using hydroxychloroquine, but the gold standard is the colchicine as treatment. And in cases of acute attack, we can utilize non-steroidals just to control the acute attack.
Yeah. Yes, I agree. I think whether the person asking this question is talking about patients who are resistant to colchicine, but hydroxychloroquine is not one of.
I think there is another question about other lines of
another
treatment.
question: what other drugs can be considered in FMF? There is no response to colchicine. Yeah.
Yeah. Colchicine is very effective in up to 95% of cases if the patient is compliant, and very, very tolerable drug with very safe margins and very low risk of side effects. But some cases are described with resistance to colchicine. If it is the case, we can use anti-IL-1, which is anakinra, in a sub-Q injection every day to control the attacks of FMF and prevent long-term damage by amyloidosis.
Yes.
The alternative to anakinra is maybe the soluble counterpart, which is canakinumab, that can be given.
Basically, it's anti-IL-1 molecule, isn't it? Yeah. Yes. Whether it is anakinra or canakinumab. Okay, we have another question. is macrophage activation syndrome, I don't know, should suspect in all sick patients, and how can we treat it as it's life-threatening? Dr. Maybe Jendal, you can answer this since you mentioned the mass in your talk.
Yeah, so mass in all systemic GIA, not in all sick children otherwise. If you have a child with some infection is otherwise sick, he or she has a tendency to develop HLH. But let's talk in context of systemic GIA. It should always be suspected whenever you have a child with systemic GIA who is continuing to have fever. The clue would be there will be clinical clues and there will be lab clues. So clinical clues would be that the child would continue to have fever, which will not come down to the baseline. So in systemic GIA, the fever goes up, comes down to baseline, then goes up. So that pattern will change, and the fever will continue to persist. It will not come to the baseline. So that will be the first clinical clue. And then these patients will start becoming more sick. They will have start having the platelet count will start decreasing. The ESR will start falling. The hemoglobin will fall. The CRP will go sky high. The transaminases may go high. So it's a very acutely developing condition. The patient may deteriorate within a span of 12 to 24 hours only. So it should be suspected whenever you have a febrile child with systemic GIA.
Yeah. So yeah, I think as you mentioned, isn't it, that the pattern of the fever is changing, where you get your persistent fever instead of the once or twice spikes of fever. And I think as you mentioned, the one of the clue is to monitor the CBC and the ESR, because if you start to see that your ESR is dropping, this is another worrying sign. And obviously the serum ferritin as you mentioned. Okay, and then we have, I don't know really whether this is a statement or a question, would follow-up echo and penicillin should be done, and for how long? I don't know the asked person who's asking, Dr. Atif, whether he means, would you,
it is post-streptococcal.
in patient with post-streptococcal reactive
Yes,
arthritis,
I think yes.
assuming that this is the question. Dr. Ziad, do you want to comment on that? So would you follow these patients that you treat for 1 year or so with post-strep reactive, would you still do echo and regular echo?
Yeah. It's not regular, but I would check echo before stopping penicillin at least. And at the start, maybe I will do echo twice on presentation and then later to make sure I'm not missing rheumatic fever.
Yeah, but not as
before
a regular
stopping
thing.
penicillin is a mandatory.
Yeah. Okay, good. Dr. Andrew is asking Dr. Jendal, can you please elaborate on Blau syndrome? This is not our topic really. How often have you seen these cases? I think Blau syndrome is one of the autoinflammatory conditions. I don't know whether if you have a quick answer, Dr. Jendal.
Yes, in fact, if you allow me, I had a case of Blau syndrome. If you allow me, I can show you that slide. How do these patients actually present? But in general,
I think the question is asking, is it common? How many cases you have?
No, it's not common. We have seen approximately 20 cases of Blau syndrome. So, but I would say that the clinical manifestation, the typical clinical clue for Blau syndrome is a very symmetric form of arthritis, which is rheumatoid factor negative, ANA negative, and they have bogey swellings over the joint. So bogey swelling is basically because of the tenosynovitis. So it's a bogey kind of swelling around the joint. So they may sometimes have a rash, which is a micropapular kind of rash, and then they develop granulomatous uveitis. So these are the
basically it's what we call infantile sarcoidosis, isn't it? So maybe we can have another session another time about autoinflammatory conditions. This is another topic by itself. And then we have Dr. Wiam asking, in neonates, most cases are septic arthritis diagnosed by MRI or hip aspiration. How long do you treat for? Again, this is really our topic. So maybe she's asking the length of IV antibiotic in neonates with septic arthritis. You can answer anyone, Dr. Ziad, do you have any answer for that? We don't get them as rheumatologists, we don't get involved in such cases. But I know that the orthopedic surgeon, they like usually to give 6 weeks course of IV antibiotic. And usually if they confirm it's a septic arthritis, they will actually even wash the joint. They open the joint and they wash the joint.
Yeah.
You want to add
yeah.
Dr. Jindal, Dr. Ziad?
Yes, septic hip in a neonate is a serious condition. It potentially can damage the growth plate and cause long-term damage to the child. So hip aspiration in this particular joint is important in infant.
Usually they open the
below
joint
3 months because the growth plate is within the joint capsule. So
Yes.
if you suspect hip septic arthritis, particularly in this joint, you will end in a court if you don't or consult orthopedic
most orthopedic surgeons will operate immediately.
aspirate that joint. The duration of treatment, usually it's a long treatment, 4 to 6 weeks of antibiotics. At least 2-3 weeks will be IV antibiotics. This is a general rule. Maybe our colleagues in infectious disease can answer this better than me, but this is a basic.
This is not a rheumatological topic, really. So that's why we need to move on quickly. So what is the pathognomic sign of GIA that sets it apart or distinguish it from other diagnoses which can be mistaken as other non-serious disease? Dr. Jindal, can you answer that?
Yeah. So basically, it's a chronic disease. I mean, as we've mentioned in our presentations, and Dr. Ziad also highlighted, this is a chronic condition. So it presents usually for more than 6 weeks. And as Dr. Ziad also mentioned that, the child is not sick looking. If the child will come walking into your OPD, all children with JIA. On the other hand, if a child is sick, is being carried in wheelchair or on the lap of the parents, that's a usually serious condition. So we have seen a couple, not couple, I mean, few patients who look like JIA, but they actually turn out to be malignancy because, because the child is acutely sick in that case.
I think the clue is then the chronicity, isn't it? Usually it's happening over a period of weeks and actually sometimes even months. Another clue is usually the muscle wasting. You see, especially when the knee is involved, you see a lot of muscle wasting and the quads. That's another indication that this process has been happening for a long time. So so usually they are not acutely ill. I think that answered the question. And then we have another question from Dr. Waleed. Greeting, I have a question regarding FMF for Dr. Ziad. Could you please highlight about subclinical episodes can cause complications similar to typical case of FMF? It's required same treatment with colchicine or just close monitoring? And what about amyloid A? It's required to do it. Again, we are cutting out of our topic of GIA. We are now moving to FMF, but there's no harm from Dr. Ziad if you can answer that, please, very quickly.
Subclinical episodes are potentially causing complications, of course, and long-term complication of amyloidosis is described on those patients, especially in particular with the pathogenic mutations, in particular M694V. So we are following patients by routine testing every 3 to 6 months, looking at the acute phase reactant, preferably looking at serum amyloid. But if it is not available or not in hand, CRP can be good enough. And doing urine and blood counts. So this periodic assessment is aimed to look for this subclinical activity of the disease or any complications that can happen from subclinical attacks. Of course, the clinical attacks are obvious and they will present with pains and they can lead to the complications more than the subclinical attacks. But subclinical activity can lead to that. And this is the aim of our monitoring of acute phase reactant and urine dipstick or protein every 3 to 6 months. I don't know if I answered the question.
So I think you did very well. Yes. So as you said, a lot of people now talk about the tip of the iceberg, that whether we are only seeing the patient with the clinical symptoms. What about the patient who has no clinical symptoms, but they still have some clinical disease? So that's why it's very important to monitor the inflammatory, because the inflammatory marker should go back to normal between the attacks, and that's very important to monitor CRP and amyloid, as Dr. Ziad mentioned clearly. Thank you, Dr. Ziad. And then we move to the next question from Dr. Marwan. Thanks for this excellent presentation. Mediterranean fever presented with joint and abdominal pain has to be treated with colchicine for life. I don't know whether it's this question or comment, any recent treatment. I think you have answered this question, Dr. Ziad, that
We have question
is the treatment if the patient is resistant, you move to anti-IL-1. I think that's the answer. You already mentioned that. Is there another question from Dr. Bravin? Is there any place for leflunomide in GIA? That's interesting question. Maybe Dr. Jendal, if you want to answer that, and then we hear from Dr. Ziad if he has a comment.
Yeah, its role is mentioned in the guidelines, as well as some of the I'm aware of many pediatric rheumatologists who are using leflunomide as an add-on drug to methotrexate in polyarticular forms of GIA, when they're not responding to methotrexate. But if you ask my personal experience, I think it doesn't work very well. Although we sometimes use, when we don't have the resources, the child is not responding to methotrexate, we add leflunomide and see the response. But in our experience, it doesn't work very well for management of polyarticular GIA. So if your patient is not responding to methotrexate, it's best to move ahead and give anti-TNF. Yeah.
Dr. Ziad, do you want to add anything?
Yeah, I never used this leflunomide. During my training in USA, our colleagues in USA, they are using that much as add-on DMARD besides methotrexate or alternative to methotrexate.
Yes.
It's potentially toxic drug. How efficient is not superior in many studies to methotrexate, but I am not using that.
Yes. I had some experience with it. Actually, if you look at the literature, it's as effective as methotrexate. Maybe there's not a lot of literature as methotrexate, but it's not inferior. It is the same efficacy. I don't think you can actually use it with methotrexate. I think it's contraindicated to use it with methotrexate because of the liver toxicity. So the patient where you are stuck with insurance that they are not approving biologics, I think it is something that you can try. I use it actually mainly in patient with no insurance and the patient who don't tolerate methotrexate. Not that methotrexate didn't work, but the patient is not tolerating because of nausea and vomiting. Actually, leflunomide is a good alternative because it doesn't cause nausea and vomiting, but it's very important that you monitor the liver function. And actually, the patient that I tried it in, it did work very, very well. I agree that we should move to biologics if we can, but not all patients can afford biologics. So a lot of countries still use leflunomide. So it is an alternative, but not add-on to methotrexate. And then we have a question from Dr. Ahmed. What is the best NSAIDs drug in hemophilia arthropathy? Again, that's not our topic, but anyway, Dr. Ziad, do you want to answer that quickly? You have
in particular, for hemophilia, I am not aware of certain non-steroidals that can be preferred in hemophilia arthropathy. But usually, naproxen is a very good concentration in the joints that can be used.
Yeah, because as you say, I mean, in hemophilia, it's not an arthritis, it's not an inflammation, it's a hemoarthrosis. You have a blood in the joint. Yes, the patient will have pain, so much maybe you can use painkiller, but I don't think there is a preference of which NSAIDs that you can use. I agree with you. Dr. Ali is asking, what about allopurinol? Is it effective for gout? I mean, we didn't talk about gout. Gout is not a disease in pediatric. We'll move to the next question, Abdullah. Dr. Abdullah, can you tell me about macrophage activation syndrome? I think Dr. Jendal has mentioned that. Can you just give us a quick summary, Dr. Jendal, about that? Because we have talked about about MAS many times.
Yeah. So the MAS, as I mentioned, it's a serious life-threatening condition in patient with systemic JIA. and it's seen in approximately 10% of the patient and can sometimes be the presenting manifestation. So like some of these patients can actually present with macrophage activation syndrome. When they present to you, they have cytopenias, and top of that, they may have some features of systemic GIA going on for last few days. So you have to have a very high index of suspicion for macrophage activation syndrome in, I think, all patients with systemic GIA who are febrile.
I think that's another topic. It can be about for 1 hour.
Yes.
So I don't think we can talk in details, but yeah, I think we have explained that. I think people need to be aware and need to be alerted about MAS, which is the other name for it is the HLH, which our colleague in Pediatric, they might come across these patients when they have infection, because secondary HLH can happen secondary to sepsis or infection, or maybe there are even primary HLH. But I don't think this is the scope of this talk to talk in details about MAS, but thank you for explaining it briefly. And then another question from Dr. Georges, what is the first antibiotic choice when I suspect septic arthritis before culture? Again, I don't think we are the right people to ask this question, but Dr. Ziad, do you want to give your comment about that?
This is out of scope of our talk. It's not about chronic arthritis, but
we didn't talk about septic arthritis. Yeah.
Yeah,
So
broad spectrum
the
antibiotics.
answer would be talk to your ID doctor, isn't it? Yes. Exactly. And then the last question is from Dr. Alia, HSP arthritis management. Dr. Ziad, how would you treat a patient with HSP?
Anti-inflammatory treatment started with non-steroidals, and relatively steroids may be indicated if the arthritis is significant or disabling. But arthritis in HSP is not an absolute indication to give steroids.
Yes.
So we start usually with non-steroidals. If the arthritis is causing much pain and limitation and swelling, then we can consider the steroid short course.
I agree. I think most patients with HSP, even if they have arthritis, usually benign, usually short-lived, is not destructive. I mean, the only reservation I have is when we use too much NSAIDs, we have to be careful with the kidneys because HSV can also affect the kidneys. So I usually, my tactics, I try to use like painkillers like paracetamol or something, but obviously if the pain is too much and the patient is not able to function, then use NSAIDs, but I would say with caution, definitely. But most patients actually recover from their arthritis fairly quickly. And it's not destructive arthritis. It looks like there's no open questions anymore.
I'd like to request Dr. Amir and Dr. Diari to add questions, especially Dr. Diari, I mean the surgical aspects.
Dr. Sharif, خلاص, he finished every question, mashallah. He took
Very
over.
comprehensive, actually, list of questions.
And make us rest. Thank you.
Dr. Diari, yes, if you have any questions, yeah, most welcome.
Thank you. No, actually, I don't have any question.
I have one question.
Yes, please.
If there is a boy, 3 years boy, have some pains, legs pains at evening, and diagnosed primary as growth pain, but the parents insist to do lab tests, but lab test comes as ANA is high, 3.9, and CCB is high, 1.58. RF negative, CBC normal, clinically normal, no limitation of movement, no swelling, no redness, nothing.
You hit a very important topic here, Doctor.
That's it. What you have to do? Only.
I mean, I think what I would say, I would not do the tests in the beginning. I would not do ANA.
I know that's what happened. They do.
But family, they don't know these tests. They might ask for general.
Yeah, some doctors.
I would not do it. I would not do it unless I clinically suspect a GIA or other connective tissue disease.
There is false positive of these tests.
There are 20 to 30% of normal population who are ANA positive, and it doesn't mean anything.
Anti-CCB.
No,
No, anti-CCP
I
is
will not
different.
do it in children unless there is polyarthritis and I'm suspecting rheumatoid factor positive.
This is
My
anti-CCP is positive.
recommendation will be, if you have a patient like this asking for these tests, refer to rheumatology. I think that will be the best thing to do. I will leave Dr. Ziad and Dr. Jandal to answer that. This
If
very
you allow
common
me,
request,
this is a common scenario.
Yes.
Somebody has requested a test and the test came back to be positive. And the test is not fitting with the clinical picture of the child now. So it's like, if it is ANA, I will leave the whole thing and might give him a follow-up in a 6 months or 3 months. And if there is any abnormal test also with no clinical context of the disease itself or justification to fit in the positive test, then I will leave the child and follow him in 3 to 6 months, look at his clinical signs. I may not consider repeating the test at all if he's not showing any signs. So this is a common
So
problem.
no preventive measurement, no preventive treatment for anti-CCP positive.
No.
May I add?
Dr. Jindal, do you have something comment to say?
Yeah, so anti-CCP should never be tested in children. It has no clinical relevance, not at all. I mean, even if it is positive, it has no clinical relevance in a child like this. So it should never be tested. So and a 3-year-old child with leg pains is a common scenario, and as has previously been mentioned, such children should not be investigated. And even if the tests turn out to be positive, they should just be reassured.
Yes. The night
question, I'd like to
if you're
interrupt.
concerned about nocturnal pain, you worry about malignancy because nocturnal pain can be a worrying sign for a patient with bone tumor or leukemia or something. So I always try to make sure that I exclude malignancy, but I will not go further than that. Please, please, please don't do, if there are a lot of genopediatricians listening, don't do ANA, don't do rheumatoid factor, don't do anti-CCP, refer to rheumatologists, let them do this investigation. It's a waste of money and make the parents very anxious, extremely anxious, and they will be moving from one doctor to the other and they will keep moving, keep repeating the test, which is completely unnecessary. So please avoid doing these tests.
Sadr, I want to interrupt you since it is very common and every day we are seeing these cases since Dr. Amir raises. Many parents, they come with the, leg pain, these are diagnosed by pediatrician, growing pain. I was reading somewhere that there is nothing like growing pain. There is some, I would like to highlight, since expert panelists are there, how you approach as a rheumatologist to a parent, because every day we are getting cases. How do you approach a child comes with every day they have pain? How do you approach? Do you call it a growing pain or what are the other things you should think of? You please highlight.
Dr. Ziad wants to answer this question.
This is a common presentation. In every child, thorough and complete physical examination and history, of course, before should alert us to any worrying sign or any abnormal sign, and then you can examine the child. One of the common things that can present with repeated joint pains, of course, in the literature you will find there is the presence of growing pain is debatable. It's not well established. There is no pathology that's called growing pain. But from our experience as a rheumatologist, hypermobility is an issue in children. It's present in, I don't know, but maybe 20 to 30%. There are no studies in my mind, but it's very common. And hypermobility in a child who is active playing during period of childhood is causing pain next night or next day. And this is a common. The message is to complete the message and to investigate. Please don't request the mentioned test by Dr. Sadek. But if you want to make sure, you can request just the blood counts, ESR and CRP, and that's enough to reassure the parents and at least exclude some of the worrying or sinister diagnosis like malignancy if the child has night pains or significant night pains. Hypermobility should be looked for carefully, and the family and child should be informed, and he should follow a certain pattern of exercise in order not to get his joints overstretched or strained and causing the pain second night. I think some symptomatic management can be enough with some directions related to the exercise the child is doing.
I mean, if we see 10 patients with joint pain or leg pain, maybe only one of them will end up having inflammatory. The majority will be just pain, what we call mechanical pain, muscular pain. So the clue is always in the history. The typical scenario, just very quickly, the typical scenario for what we call growing pain, whether you believe on it or not, the mother will tell you the child wake up at night crying. Usually they will point to the calf muscle. Okay, they will not point to the joint. Okay, and it's usually bilateral. The mother will massage the legs, the child will fall back to sleep. The next day, they will be absolutely normal. Look for the red flags. As long as the child is not limping, not unilateral, and it is not a bone pain, it's usually muscular pain. But the message, if you are in doubt, if you cannot reassure, refer to rheumatology. I think that will be the message. But investigating, you might actually make the parents more anxious rather than less anxious. Dr. Diari?
Sorry, I was just mentioning like that they are usually, when they are coming, it is a diffuse pain, not localized to one area when they are saying, and it is usually bilateral in both legs.
Absolutely.
Yeah,
absolutely. This is the clue. If the mother says it's always this one leg, or if they say the child is limping the next morning, then that's a red, or if they point to the bone. So
yes, localization.
Majority, as I said, you can actually, I don't investigate. When I'm happy that this is typical history, I don't even do investigation, but I will not go more than CBC and CRP if I have to. But autoantibodies, a lot of families don't even know about them. So actually the doctor can reassure and say that there is no need to do them. And I really strongly recommend that please stop doing these tests. Now, I don't know what's happening. Maybe my colleague noticed the same thing. A lot of GPs and general pediatricians now are doing ANA as part of a routine test with CBC, vitamin D, TSH, and they do ANA. Even if the child doesn't have joint pain, they do it even for the child who have a bit of fatigue and a bit of tiredness. So the ANA became a very, very common test actually these days. I don't know why, but I'm getting a lot of referral to the clinic. I don't know if my colleagues wants to comment on that, if they have the same problem. Dr. Jindal?
Yeah, so in India, I think I mean the general pediatricians do not do ANA very frequently. I mean in a normal situation, but they do ANA, and I think a lot of whenever there is a suspicion of a connective tissue disorder, even in children with non-specific leg pains. But what I've observed, I'm not sure of what is the situation in UAE, but they do a lot of rheumatology panels or ANA profile, or all kinds of things. And that includes rheumatoid factor, CCP, immunoblot, all kinds of things, which probably do not give any diagnostic importance in these non-specific complaints. So I think that should be avoided and should be left to rheumatologists to decide.
Yes, absolutely. Don't go too far. I mean, if you feel that you need to do further investigation, refer to the clinic. Better to refer before the test rather than after the test. Any other questions? I think there are two questions in the Q&A. Dr. Fadil.
It's just a comment.
It's a comment actually about the hypermobility.
He's agreeing with
hypermobility is very, very common. Flat feet with ankle pronation. We see that every day. And these kids will have pain and aches usually in their lower limb, which is usually what we call mechanical or muscular pain that has no significance. I think we're coming to 11 o'clock. So maybe we can say to close, we can give 1 minute to Dr. Ziad and 1 minute to Dr. Jindal to wrap up and close the session. Dr. Ziad?
Thank you, Dr. Shorab. Thank you, Dr. Jindal, Dr. Sadiq, and all the attendees and the audience. It was a rich discussion. Hope we were successful in delivering some messages to our colleagues in pediatrics regarding common things and lessons in pediatric rheumatology. And I am happy to be part of this presentation and webinar. Thank you all.
Thank you. Dr. Jindal?
Yeah, thank you, sir. And thank you everyone for giving me this opportunity. It was wonderful interacting. I mean, not only teaching, but I think it was a lot of learning experience as well for me. So happy to be part of this webinar, and I look forward to many more such webinars in the future. Thank you, sir.
Thank you. So thanks to Dr. Ziad, thank you, Dr. Jindal, and thank you to Dr. Sahrab for inviting me to be in the panel, and Dr. Diari. It was your idea, and I'm not regretting being part of the team, really. Thank you, Dr. Amr. Dr. Sahrab, do you want to close the session?
Yes, I would like to thank Dr. Jindal, Dr. Ziad, Dr. Sadr for excellent moderation. So we will invite you for future rheumatology sessions. I would like to thank Dr. Diari, Dr. Amir. Dr. Kalpana was not there. Once again, I would like to give this message, Happy Diwali to all Indians, because tonight actually is a festival of the lights in India, Diwali, and many of our colleagues, including Dr. Kalpana, could not attend because of this. I would like to thank Tawfiq for sponsoring this webinar. I would like to thank all viewers staying with us till now and following us. Here, I would like to mention that we are going to have our 8th annual Dubai Pediatric Club Conference on 26th and 27th of November. 26th is a physical face-to-face conference. At night, we will have gala function in a unique Queen Elizabeth II hotel. This is the only floating hotel in UAE. So all are welcome. On 27th, we will have webinar. From all over the world, they can attend, and free registration for all. Both conferences are free registration. Of course, physical is for pediatrician. Once again, I would like to thank all of you, and really I enjoyed, I learned many things. Thank you very much, and good night.
Thank you very much. Thank you. Have a good night. Thank you all.
Thank you.
Thank you.
Thank you. Good night.
Thank you. Bye.